This is William Huang, and now we will turn to ethical principles that may be encountered on the exam. These topics and questions may seem less concrete than those from other lectures, but they require an understanding of the ethical and social aspects of medicine. There are also many so-called quote questions on the exam that will require an understanding of medical ethics and medical law, key aspects of the doctor-patient relationship, and how to respond to patients' questions. There are four core principles in medical ethics: autonomy, beneficence, non-maleficence, and justice. Autonomy is the obligation to respect patients as individuals and to honor their preferences in medical care. This also applies to patients refusing care. A patient who is competent and over 18 has the right to refuse treatment at any time. Beneficence is the notion that physicians have a special ethical duty to act in the patient's best interest, which at times may conflict with autonomy. If the patient can make an informed decision, then ultimately they have the right to decide. Non-maleficence is simply the physician's obligation to do no harm. However, in situations where the benefits of an intervention outweigh the risks, a patient may make an informed decision to proceed with the intervention, even if there is a chance that the intervention may result in harm. Can you think of a situation where benefits and risks are routinely weighed against each other? Well, this is the case for most surgeries and even medications. Finally, justice is the physician's ethical obligation to treat all persons fairly. Informed consent is a straightforward medical legal principle and requires three separate conditions to be met. First, there must be a discussion of pertinent information with the patient. Second, the patient must agree to the plan of care. Third, the patient must be free from coercion. Essentially, informed consent requires that the patient understand the risks, benefits, and alternatives of a decision, which includes no intervention. On the exam, exceptions to informed consent are more likely to be tested than informed consent itself. If a patient lacks decision-making capacity or is legally incompetent, then there is no requirement for informed consent. Similarly, there is always implied consent in a medical emergency. Also, withholding information when full disclosure would severely harm the patient or undermine informed decision-making capacity can be an exception to informed consent. This is called therapeutic privilege. An example may be a depressed, suicidal patient who has a new diagnosis of terminal cancer. Since this is a controversial topic in clinical practice, however, you can be pretty confident that invoking therapeutic privilege on the boards would be the wrong answer. Finally, patients may always waive their right to informed consent. Consent for minors is sometimes a tricky issue and is commonly tested. A minor is defined as any person less than 18 years of age. Parental consent must be obtained unless the minor is emancipated. Emancipation occurs when the minor is married, is self-supporting, has children, or is in the military. However, parental consent is not required for emergency situations, contraceptives, treatment of STDs, medical care during pregnancy, and management of drug addiction. It's also worth knowing that parents, even if they are competent to refuse their own treatment, cannot refuse treatment for their children in life or death situations. Medical decision-making requires 5 conditions to be met. First, the patient must make and communicate a choice. Second, the patient must be fully informed. Third, the patient's decision must remain stable over time. Fourth, the patient's decision must be consistent with their values and goals. And fifth, the patient's decision must not be the result of delusions or hallucinations. Also, it is worth remembering in these types of questions that a patient's family cannot require that a doctor withhold information from the patient. Again, there shouldn't be any reason to invoke therapeutic privilege on the test. Can you think of a common situation in which a patient would temporarily not have medical decision-making capacity? Being drunk is equivalent to being incapacitated, and thus, intoxicated patients that show up to the ER do not have medical decision-making capacity. Advanced directives come in many different forms. Advanced directives are defined as instructions given by a patient in anticipation of the need for a medical decision. An oral advance directive is an incapacitated patient's prior oral statement commonly used as a guide to their wishes. If the patient was informed, the directive was specific, the patient made a specific choice, and the decision was repeated over time, then the oral directive is more valid. However, if any of these conditions do not hold, then problems can easily arise from differences in the interpretation of the directive. A living will is also called a written advance directive. Here, the patient describes treatments he or she wishes to receive or not receive if he or she becomes incapacitated and cannot communicate treatment decisions. In most cases, the patient will direct the physician to withhold or withdraw life-sustaining treatment if he or she develops a terminal disease or enters a persistent vegetative state. Finally, durable power of attorney is when a patient designates a surrogate to make medical decisions in the event that he or she loses decision-making capacity. In this context, the patient may also specify decisions in certain clinical situations, similar to a living will. The surrogate retains power unless revoked by the patient, making this more flexible than a living will. If an incompetent patient has not prepared an advance directive, individuals who know the patient, called surrogates, must determine what the patient would have done if he or she were competent. The priority order of surrogates is spouse, adult children, parents, siblings, and then followed by other relatives. Confidentiality means that you must respect the patient's privacy and autonomy and cannot reveal any medical information you learned while treating that patient. How would you approach disclosing information to a patient's family and friends? Always remember that disclosing information to family and friends should be guided by what the patient would want. Also, the patient may waive the right to confidentiality, which often occurs with insurance companies. Again, for the purposes of the boards, it's more important to know about exceptions to confidentiality as opposed to confidentiality itself. If the potential harm to others is serious, or if the likelihood of harm to self is great, then the patient's right to confidentiality is no longer valid. Moreover, if no alternative means exist to warn or protect those at risk, then a patient's right to confidentiality is no longer valid. In these situations, you may be required to take steps to prevent harm to the patient or others. Can you think of some examples in which these exceptions would come into play? These exceptions would be relevant for certain infectious diseases in which physicians may have a duty to warn public officials and identifiable people at risk. Also, in cases of child or elder abuse, impaired automobile drivers, and suicidal or homicidal patients, these exceptions always apply. One important court case to know about in this setting was a California Supreme Court ruling called the Tarasoff decision, which led to the creation of a law requiring physicians to directly inform and protect potential victims from harm, even if this involves a breach of confidentiality. The boards loves to present questions concerning ethical decision-making. This is an extremely high-yield topic to review, but given the number of situations that could be presented, it is difficult to cover every possible ethical dilemma you could be presented. To review this material, it is best to understand a few general principles and apply them to diverse situations that may arise. Another very high-yield point to remember with ethical questions is that the correct answer is almost never going to be referring the patient to another physician, regardless of the situation presented. When given the answer choice to refer the patient to someone else, there's always going to be a better answer choice listed because the test makers believe that the original physician should handle all ethical situations, and referrals are both unnecessary and unprofessional. Let's go through some examples now. If a patient is non-compliant, the best response is to try to identify the patient's reason for non-compliance and determine their willingness to change their behavior. The most important point here is to never coerce the patient into complying. As an example of patient non-compliance, if a patient continues to smoke despite repeated counseling sessions, the appropriate response is to ask the patient how they feel about smoking and offer advice on cessation if they express an interest in quitting. What about medication non-compliance? If a patient is having difficulty taking their medication, the appropriate response is to provide written instructions and attempt to simplify the treatment regimens. Another common scenario is when family members ask for information regarding a patient's prognosis. Remember the ethical principle of patient confidentiality. The appropriate response here is to avoid discussing these issues with relatives without the explicit permission of the patient. Similarly, if a child wishes to know more about his illness, the appropriate response is to ask the parents what they have told the child about the illness, because the parents of a child decide what information can be relayed. Pregnancy is another high-yield ethical situation to review. If a minor is pregnant and requests an abortion, the appropriate action is not to advise the patient to have an abortion regardless of her age or the condition of her fetus, unless she is at medical risk. Also remember that many states require parental notification or consent for minors to have an abortion. Another scenario is that a minor is pregnant and wants to keep the child, but the parents want her to give the child up for adoption. The correct action to take here is to provide information to the patient about the practical issues of caring for a baby and discuss the options with her if requested. Also, you should encourage discussion between the teenager and her parents to reach the best decision. The key here is to remember that the patient always retains the right to make decisions regarding her child, even if her parents disagree. Thus, the parents can never force her to give her child up for adoption. Another topic to review is suicide. If a terminally ill patient requests assistance in ending his life, you must always refuse involvement for the purposes of the boards. However, physicians may prescribe medically appropriate analgesics for pain control, even if it happens to shorten a patient's life. How do you think you should approach an interaction with a patient who is suicidal? If a patient is suicidal, then you must assess the seriousness of the threat and suggest that the patient remain in the hospital voluntarily. Remember that in these situations, the patient can be hospitalized involuntarily if he or she refuses to be admitted because the patient is deemed to lack decision-making capacity. In scenarios where a patient states that he or she finds you attractive, you must remember that romantic relationships with patients are never appropriate. Never tell the patient that there can be no relationship while he or she is a patient, because this implies that a relationship would be possible if the individual is no longer a patient. In these situations, ask direct, close-ended questions and use a chaperone if necessary. If a patient ever states that they feel ugly, find out why the patient feels this way, but do not offer false, reassuring statements like, "You still look good." These are trap answer choices and will always be incorrect. The appropriate way to respond to a patient who is angry about the amount of time he spent in the waiting room is to acknowledge the patient's anger without taking it personally. You should apologize for any inconvenience, but you should stay away from efforts to explain the delay. If a patient is upset with the way he was treated by another doctor, the appropriate response is to suggest that the patient speak directly to that physician regarding his concerns. If the problem is with a member of your office staff, tell the patient you will speak to that individual yourself. What happens when a physician makes a medical error? Regardless of how serious or trivial the error is, the physician is ethically obligated to inform the patient that a mistake has been made. If a drug company offers a referral fee for every patient a physician enrolls in a study, the appropriate action is to never accept compensation from a drug company. However, eligible patients who may benefit from the study may be ethically enrolled, but they should be informed of the existence of a referral fee and the fact that you decline the compensation. If a patient requires a treatment that is not covered by his insurance, you should never limit or deny care because of the expense in time or money. Discuss all treatment options with patients, even if some are not covered by their insurance companies.